when we facilitate skin to skin time, even with really small, sick babies, not only is it safe, but we see babies' stress levels decrease, their cortisol in their blood decrease, their sleep improve, their length of stay in the hospital decrease, their time towards oral feeding is shorter. Like literally every outcome that we measure when parents are touching their babies is safe and it's positive. And so I think partnering with the medical team and the parents is so important as neonatal therapists with this knowledge and this information that we have. And we can help set this up in a safe and successful way so that parents can do skin to skin early on and that babies do get that benefit and parents get that benefit too.
I'm Rachel.
And I'm Jessica, and this is All Things Sensory by Harkla.
We are both certified occupational therapy assistants, and together with Harkla, we are on a mission to empower parents, therapists, and educators to help raise confident and strong children of all abilities.
On this podcast, we chat about all things sensory, diving into special needs, occupational therapy, parenting, self-care, overall health and wellness, and so much more.
We are here to provide raw, honest, and fun strategies, ideas, and information for parents, therapists, and educators, as well as other professionals to implement into daily life.
Thank you so much for joining us.
Hey there, welcome back to All Things Sensory by Harkla. We're so happy to have you today. I'm Rachel.
And I'm Jessica, and today we are talking with Angela. She is a PT who works in the NICU and surprised us when we found out that she's actually local to us. She was recommended by a friend, so we're really excited to talk with her today about all things NICU.
Yep, so let's jump in and meet Angela. Hello, Angela. Welcome to All Things Sensory.
Hi, thank you so much for having me. I'm so excited to be here.
Awesome. Well, first we need to start with our secret questions. We always ask 5 secret questions so that we can learn everything about you.
Perfect.
All the deepest, darkest things. Okay. All right. First question. What is the most unusual food you've ever tried?
Probably a cuy, which is guinea pig. In Peru, I went on a medical trip to help kids with disabilities in Cusco, Peru. And that's one of the delicacies is they eat like roasted guinea pig called cuy. And it's not my favorite thing ever, but it was a cultural experience. It kind of tastes like sweet ham. But that's probably the weirdest thing I've eaten.
Oh,
Yep.
Okay.
Yep. That's a good one.
We have good questions for these people. They're very fitting.
All right. If you had to pick a theme song for your life, what would it be?
Oh, that is such a hard one. I guess one that I sing to myself all the time is I'm on top of the world. I think it's Imagine Dragons.
Yes.
That's where I'd like to think I am, so it's my manifesting theme song. Definitely not my usual everyday.
So good. So good. All right. If you could have any animal as a pet, real or mythical, what would it be? Don't say guinea pig. Don't say guinea pig.
That's an easy one. Okay. It will not be a guinea pig. It'll be an otter. It'll be an otter. My favorite animal. So my t-shirt says otterostomy. So it's an otter that has a little ostomy bag. So that would be my pet for sure.
Otters are pretty cute.
They are.
I actually have an otter tattoo also. So
they are.
That is
an
easy choice.
Great question for you.
Would you rather feel always slightly itchy or slightly ticklish?
I absolutely hate being tickled. So not that I love being itchy, but I think I'd rather be itchy than tickled. Yeah. I don't like being tickled.
I think I'm in the same boat. It's a rough one.
Yeah.
Yes, that is a rough one.
Okay, going along with that, because we are a sensory-based podcast, what is your sensory quirk?
Oh, I have quite a few. You, like, OT people will, I need your help. I cannot stand cotton. I can't touch cotton balls. I can't touch cotton swabs. I don't even like a deep cotton towel. No, I don't like it. So that is my one of my many weird sensory things. Yeah.
We work with someone who has that same sensory quirk. She cannot touch.
Pulling the cotton balls out of
No. My worst nightmare. I can't do it.
That was a big reaction. We do need to therapize you.
You do. I need help.
And not by desensitizing you, because that is not the route.
Clearly not.
I've tried that. My OT colleagues in the past have tried that, and it's not been successful so far, but I believe there's hope.
Oh my gosh, that was so funny.
We'll just accommodate. It'll be okay.
All right, now that everyone knows all of your deepest, darkest secrets, tell us who you are, what you do, why you do it, all the beautiful things.
Well, I am a neonatal physical therapist, so I have been practicing for over a decade. I graduated from the University of Washington with my doctorate in physical therapy in 2014, and I've been practicing in pediatrics ever since. Over the past about 7 years, I've been specializing in neonatal therapy, so infants, primarily in the NICU, but I do work in kind of a variety of settings with medically complex infants. I recently moved to Boise, where y'all are.
What?
You're here in Boise?
Why did you tell us this? We would have had you here.
So, actually, funny story. I was in Seattle for the past 13 years, and my husband and I were considering moving to Boise, and I was feeling really nervous about just like moving states and moving institutions. I'd been at Seattle Children's Hospital for a long time. I felt really kind of confident and secure there. And I was like, what is healthcare going to be like in Boise? It's a smaller town. And then I came across your guys' account and I was like, wow, there are some really cool healthcare providers doing awesome things in Boise. Like I can go to Boise and do awesome things too. So we moved here in June.
Wow.
I work at St. Luke's Children's Hospital, primarily in the NICU, and it's been an amazing transition so far.
Okay, so then you are referred to us by Amy. Do you know her personally?
I know her through Pure Bar.
Okay.
Yeah, so we work out together.
Gotcha. That is so funny. I had no idea. I thought she just followed you on Instagram and liked your content and thought you were great. And I was like, oh, that's great. That sounds great. But no, you guys actually know each other. I
think that's how we originally connected. And then like we just realized that we go to the same studio and work out together. And like she's so strong and amazing. So
she is. She's surprisingly strong.
Yeah.
Oh my gosh, that's so
that's
funny.
A small world because I knew that you were from Seattle and I grew up in Spokane, so I was like, oh, Washington.
Oh yeah, yeah.
It's bigger than that.
It's
now.
even more. Oh my
god.
Yeah. We'll need to hang out.
Absolutely, I know. I would love that.
Oh my gosh,
it's been great so far.
Wow. Okay, let's get back to it. What are we even talking about?
I don't know.
First things first. Tell me what PT looks like in the NICU.
Yeah, so a lot of times when I tell people that I am a PT in the NICU, they are really surprised. And the most common response is, I didn't even know there were PTs in the NICU. Neonatal therapy is such a special kind of subspecialty within physical therapy that looks a lot different than like your kind of like traditional thought about physical therapy. I like to describe it to people as, like traditional physical therapy, we often call rehabilitation, whereas NICU therapy, I think of more as habilitation. So rather than kind of like fixing a challenge or kind of working through a challenge that has been acquired, we are really there to kind of set babies up for success and kind of roll out the red carpet for their development as best as we can from the get-go. So in the NICU, I help with itty bitty tiny babies, really sick babies. We work on positioning, we work on their posture, we work on sensory stimulation, like kind of safe and evidence-based sensory stimulation based on their gestational age as they grow. I work with parents a lot to help them feel like safe and comfortable with holding their baby and touching their baby and just kind of like working with them with each stage of their baby's growth and development. I love to be creative and to make like different like positioning types of equipment or splints or kind of like just being super creative. My OT colleagues tell me that there's a little bit of OT in me there too. I love to do splinting and like just be creative to kind of like use what we have to meet goals. And then as babies get older, we do tend to work on more kind of traditional developmental milestones. So we work on head control and rolling and tummy time and all sorts of like kind of baby skills. But NICU therapy looks a little bit different with the itty bitties.
Yeah, for sure. Let's talk about tummy time. That's something that we talk about a lot, and the importance of tummy time from day one. And how are you helping these babies get that tummy time in a safe way?
Yes, I was so excited that you reached out to talk about that because I'm really, really passionate about helping babies, regardless of their medical complexity, regardless of their age and what's going on with them, be able to do tummy time safely. Because we know that tummy time is so important for all aspects of development. It's important for motor development, sensory development. It's important for postural control. It's important for muscle tone. It's important for oral motor skills. It's just like, it's such an important developmental play position for babies to spend time in. It helps with head shaping. I mean, I can go on and on about why tummy time is important. And so one of my favorite things to do is to be creative about how we can help babies do tummy time. So in my NICU currently, I'm making custom prone positioners for really tiny babies. So I measure them and I measure their length. I measure their shoulder width and their hip width, and I kind of cut out these little like foam I call them like surfboards, so that babies can be kind of propped over the surfboard, and because they're so small and so like medically fragile, we need to make sure that their joints are really protected. So I cut it so that their shoulders can be rounded and their hips can be rounded. They can still be in that kind of tucked flexed position that is so important for neonates as they're developing while on their tummy. We can swaddle them in that little foam prone positioner. We create nests to keep them like safe and tucked. We make sure we turn their head both directions. And I work really closely with our respiratory therapy colleagues because that often means we need to switch where if babies are intubated, where their tube is going. And so we really try to be mindful of this right from the get-go so that these even preterm babies are getting a variety of positions throughout their day, and they're getting used to this posture, and they're getting off of the back of their head. And we have a phrase in the NICU that we say, face down, sats up. Like the babies breathe better on their tummy. They have better physiologic stability. They're often really, really comfortable here. We see them sleep deeper. And so we have to be a little bit creative, but we try to work that into their daily routines.
Mm-hmm. I love that. I have a question. I recently came across a device that I've seen used in the NICU setting, and it basically looks like what you described, but it's for older babies too, and it's like a little skateboard, and you can strap them onto it, and it kind of helps them learn to crawl too, and it helps them with the reciprocal movement of crawling. Have you ever seen that before?
Yeah, actually, I was lucky to be given one in Seattle. If it's the same device that you're thinking of, it's called the Joey. It's from Daytot.
Yes.
Yeah. That's the one I'm familiar with. And that is exactly what you described. It's kind of this little skateboard that the baby is strapped into safely and really helps to facilitate that early crawling movements. And I have had amazing success with that, especially with babies who have significant motor delays. It helps them be able to tolerate tummy time better because we can add in some movement. We can rock them back and forth. They really don't have to do much. So even babies who have challenges with muscle tone and strength and activation, they can still get some mobility. And that's one of the biggest things about tummy time is that we need to show babies we need to show them the trade-off. We need to show them kind of like why tummy time is important instead of just hard work. And so mobility is one of the big ones, especially for older babies. And so if we can show them like, hey, if you wiggle on your belly, you get to move and you get to explore your environment, then it's huge for them. So I am a big fan of that product and really was lucky to get to use it. Highly recommend.
It is I had to look it up and see, but it is. And it's like got a handlebar so you can like help them move and crawl.
Yeah, it's amazing. And they have different sizes and you can build it up higher for bigger kids who you want to work on maybe like 4-point crawling on hands and knees, or you can put it down lower for babies who are just trying to kind of do some belly crawling. it's really comfortable. And I mean, I've had babies who really, really struggle tolerating tummy time be able to do significant amounts of time in it on the Joey because of that vestibular aspect and that movement experience that they love.
That's cool. Okay, thank you. Because I had never seen one before, and I was doing research about crawling, and I was like, this is a really neat product. So I'm glad that you've actually used it and you can attest to it that it actually works.
Yeah, I have a lot of videos of babies using it. So if you want to see more, I'm happy to share.
That'd be great. Yes.
Yeah.
Okay. So the other thing that I wanted to kind of touch on was G-tubes. And I'm sure you work with a ton of babies with G-tubes. I remember we worked with a baby with a G-tube a lot, like way back at the beginning of our career.
Yeah, he was a toddler at the time, I think.
Yeah, so he was an older toddler, but we still, I mean, tummy time was just nearly impossible to do with him. And so would you share some tips on how either parents or therapists can
Both, probably.
Both.
Yeah.
Facilitate that.
Yes. Well, I will say, I think it starts in the hospital, right? So by the time babies get to you and they hate tummy time, we have just made your job a lot harder. And there's a lot of steps that we can take pretty close to right away. Usually most surgeons that I've worked with have wanted babies to avoid tummy time from anywhere from 10 to 12 days before they do full on tummy time. And just to make sure that that site heals and that we're letting that skin and that stoma, you know, the wound where the G-tube has gone through, but lets it fully heal and set. And then after that, babies are typically cleared for tummy time. And I think that's a piece of education that often gets missed in the NICU, is that parents think, oh, we must stay off our tummy for a long time. This is a big thing. This, you know, my baby can't do tummy time. A lot of times even the NICU staff are not aware of those precautions. And so I think early education about the safety of tummy time pretty quickly after G-tube surgery is really important. And I think finding ways to do that are going to be comfortable and help the baby tolerate it is crucial. And so oftentimes I'll start out by having parents do tummy time on their chest after G-tube surgery, or in their arms, like in a little football hold, or we'll prop a little like pillow underneath them, things like that, that really kind of help baby get back into the position. And hopefully, you know, by the time they got their G-tube, they had already had previous experience with tummy time too. Because I think that really helps ease the transition in. If babies are able to do tummy time before their surgery, so that it's not such a hard transition to go back into it.
Yeah, for sure. What about, do you help transition these babies home and give them almost like a home exercise program, things to do at home once they leave the hospital?
Yes, absolutely. That's an important aspect of it too. I really like to make sure that parents and families and babies are all comfortable with the tummy time plans before they go home. So if they can just do tummy time on the flat crib and that's comfortable for them and parents feel comfortable, then great. If they need modifications or some changes, I try to make sure that I help them with that and we do that before they go home so they can be more successful. So some things that we can use to help with that transition are blanket rolls, just rolling them up and putting them underneath their chest so that it takes some of the pressure off the site of the G-tube. And usually babies don't need that for long. Sometimes we can do it over a boppy, again, hoping to transition out of that pretty quickly. There's also like G-tube belts and G-tube pads that you can buy on Etsy or crafty people can make that help stabilize the site of the G-tube so it doesn't kind of move around and potentially like get irritated when babies are doing tummy time. And so those are some things that I explore with parents to help them figure out a good plan for tummy time before they're going home. I'm lucky in the system that I work in that we work directly with our home care therapist so that when babies discharge, they go directly to our same system often. And so we get to work together a lot and kind of problem solve together about how to help that baby move forward. And I would say the majority of the time, if we start this like early on and we are consistent with our recommendations and giving this baby exposure, that we can be pretty successful in getting babies to just kind of get back to their typical recommendations of tummy time.
Mm-hmm. I think that's so important, educating the families about why tummy time is so important. You know, it's not just to prevent them from having a flat head. Like, it truly does set them up for success in the future. And it's such a small component. And maybe you can share some tips for kids who are really pushing back against tummy time or who are really uncomfortable with tummy time. My favorite thing is just to get down on the floor with them and lay across from them. And that way it's a little bit more exciting too. But I think that it's okay that babies, it's okay that they protest. It's okay for them to communicate that and to say, this is uncomfortable. And we can get down on the floor with them and say, yeah, this is uncomfortable. We can do it. Let's sing a song. Let's work together. Let's look in the mirror. And just to be present with them rather than, oh, they're upset. Let's pick them up and, put them in a what are those? The bumbo chairs. Let's put them in a bumbo.
Yeah. Yes, I totally agree. And a lot of the things you recommended are things that I recommend. Floor time, like getting down on the level of the baby and playing with them, is so helpful. Distractions and motivation is also so important. Like you mentioned, a mirror. I love using mirrors. It's really motivating for babies. I also recommend that parents find a toy that is kind of like their like favorite, like super special toy that the babies love, and then they only do it during tummy time. So even though tummy time is hard work, the baby gets rewarded by getting to play and engage with that favorite toy when they're doing their hard work. I think keeping in mind too that just like we don't always want to go work out all the time at every moment of the day, babies are the same. And like you said, it's okay that they protest. What I always recommend is to work tummy time into parents' daily routine at several different intervals, maybe before each like daytime feed, for example, so that there might be a time where baby wants nothing to do with tummy time. So that's okay. We just do a short burst and we move on to a different play position. But maybe later that day when we try it, they're loving it and they're totally into it and they can do it for 20 minutes. So if we're giving them multiple opportunities, we're more likely to find a time that they're going to love. There are some babies that just do not like tummy time, like no matter what we do. And so we have to be creative and strategic and kind of like changing their association of tummy time to being something they don't like. And so oftentimes I'll tell parents to back it up and let's go back to those newborn days of just doing tummy time up on your chest, where you're holding them and you're rocking them. Maybe you're even baby wearing them if they're still an appropriate size. But they're really kind of just, we're going back to that comforting, supportive tummy time in arms, where sometimes babies can even forget that they're doing tummy time and they just think they're cuddling. The football hold is another good one. Tummy time in parents' arms. You can walk around, you can rock them, you can give them nice vestibular input. I like using a yoga ball or therapy ball and having babies like kind of roll over and side to side on tummy time. That movement, again, I think is really helpful. Bubbles are another good motivator that also encourage like head lifting and looking around to kind of like look at the bubbles as they're falling all around. So we just have to be creative. And I think working with your therapist to kind of help find some of those strategies is a great way to kind of partner with your therapy team and the parents to help the babies be more successful.
Yeah, therapy ball is always my go-to too.
Yeah, and taking it back to the basics. I think we get caught up in like, no, we're regressing if we're doing that. But it's like, no, we need to get that joy back and that enjoyment back. So I love that.
Yeah. Do you have a recommended amount of time for tummy time for babies? Is it dependent on their age, on how long they should be in tummy time?
Yeah, so that's a great question and one that parents often ask. And the American Academy of Pediatrics, or the AAP, recommend to kind of optimize developmental opportunities that babies be participating in tummy time for about 60 minutes a day. So an hour a day. Well, my little phrase that I always tell parents is, back to sleep, but tummy to play. An hour a day keeps the PT away. So that's kind of the goal that we aim for. But of course, like it depends on the baby. It depends on their age. I don't expect a newborn baby to really be able to do like tummy time for an hour on the flat floor mat. So I usually recommend, based on experience and guidelines from the CDC and the AAP, that by about 3 months of age, hopefully babies are reaching that goal of an hour a day. And so if we start out by offering 3 different time periods from early on, where babies might just do a couple minutes each time, hopefully that tolerance will build each time period, and, interspersed throughout the day, they're getting, 20 to 25 minutes each time, and we can easily meet that hour. And I think it's important to remember too that, it doesn't have to be the same play period. It can be broken up throughout the day. And so I really think that's important, because there are almost no babies I know that could do an hour straight of tummy time, and they're not supposed to. Yeah. So we break that up, and we give them breaks, and we give them different opportunities to play in a variety of ways.
Yeah. My babies would always fall asleep on the floor doing tummy time.
Yeah. Yeah.
I'm like, hey mom, this is enough. I'm just going to go to sleep now.
Yeah. And, I always, tell parents too that resting tummy time is beneficial too. Yeah. They're still getting good sensory input. They're still getting pressure off the back of their head. They're still getting that nice postural positioning. So as long as they're supervised and you're watching them, they can take little rests when they're doing tummy time, and that's beneficial for them too. Obviously, we know that the most gross motor and strength gains happen when babies are awake and active and pushing and lifting. But there's benefits that come from a restful tummy time too.
Yeah. Okay, what are your thoughts on primitive reflexes?
Primitive reflexes are an interesting concept that I don't do a ton of anymore, because my babies usually are just kind of first developing them. I think where they become more of a hot topic is when they remain present. And I definitely have seen that when I've worked with older kids too. I would say that's probably more your guys' specialty area than mine. But we talk about those things, and I know that early positioning has an impact on that. So, for example, like the ATNR, or the asymmetrical tonic neck reflex, or the fencing reflex, if we are not promoting symmetry in babies early on, especially when they have a prolonged hospital stay, it's really common for them to have a head turn preference, which can turn into torticollis, which can turn into sustained ATNRs on that side and less active ATNRs on the other side. And we can see those asymmetries and those difficulties persist into early childhood. So I really think that, our positioning that we're doing early on is really helpful to set babies up for success when it comes to integrating reflexes. And I know that's a hot topic that's debatable, but I think we can only do good by setting them up for success early on.
Yeah. What kind of what kind of positions are you talking about? Tummy time is probably one of them, but what other positions are you putting babies in?
So if you think about a baby in utero, they are kind of suspended in space, ideally, in a flexed fetal position, right? That fetal position that we kind of all talk about. And that is a very purposeful position that helps to develop postural control in a really meaningful and typical way. So when we take a baby out of that kind of perfectly primed uterine environment, and we leave them exposed to the weight of gravity, which for really small babies is very, very heavy. If we don't support them, they are going to be pancaked. They're not going to be able to move much against gravity. They're not going to be able to alternate their positioning. They're not going to be able to get into that tucked position that is so healthy and helpful for their development. And so it's up to us to help them with that. So we think about midline, neutral, flexed positions for neonates in all different positions. So on their back, we want them in that flexed position. We'll often use what we call a nest, which is blanket rolls or bumpers or positioners to give them that kind of 360-degree circumferential containment support to keep them tucked in. The same on their side. We'll use different rolls and different positions to keep them neutral. And then, of course, tummy time. And then when I'm working with them, we always come up into supported sitting. It's important for their spinal development and their postural erectors and their head control and their visual alertness. And so we always spend time in upright as well. And the variety and the variability and just changing positions is important for babies, because the NICU can be a very protected and kind of safe environment, which is really important. But also we know that the uterine environment is not like that. That babies are getting movement. They're experiencing movement as the pregnant person is moving. They're hearing things through the wall of the belly. They're moving within the amniotic fluid themselves. They have freedom to extend and move. And so we need to help replicate that as much as possible when babies are out of the uterine environment and still relying on, us to kind of like help promote some of those normalized movement patterns. So we have lots of different types of equipment that we can use. I brought one here. It's called a Z-Flow, and it's one of my favorites. It's very moldable. You can kind of squish it however you need to help support the baby. So we use this for preemies. We also use it for medical complexity. So for example, like a baby fresh out of a G-tube surgery who's cleared for tummy time but is still a little bit tender, we can do it over this Z-Flow, and I can mold out a little hole so that there's no pressure on the G-tube site. We could do the same thing for like my little osteotomy, like kids who have ostomy bags that are really kind of tender, and we have to be careful that we're not going to pull them off. Same thing. We kind of put them tummy time over the Z-Flow, and I can mold it so that there's a nice little groove for the ostomy bag to be protected. So using positioners to our advantage is really helpful in making sure that we're promoting these healthy and safe postures and movements for babies.
I love that. Okay, here's a weird question. I have no experience in the NICU, so this might sound silly.
No silly questions.
In my head, babies should most of the time generally want to be head down in utero, right? Mm-hmm. So they're getting they're getting a lot of vestibular input. I know that they're in the womb, so there's fluid, so things are obviously going to be different. Mm-hmm. But I guess my thought is, how can we replicate that or facilitate that in our preemies or in our babies who were breech or, and never got that like head down position to stimulate their vestibular system? Does that make sense?
Yeah, it does make sense. And it's a tricky one. So with the itty bitty babies, the safest position for them when they're out of utero because of blood flow is to actually have their heads elevated. So any like preterm brand new babies, usually for 48 hours, will be head of bed elevated to 30 degrees and midline without moving because their blood vessels are really vulnerable. We have to monitor their blood pressure really closely because they're at risk of having a brain bleed. And so outside of that, we have a little bit more freedom, but for those early days, we really do protect babies head up in order to protect their vascular system. Vestibular development is honestly something that I think in the grand scheme of the NICU world gets kind of forgotten about and gets kind of pushed to the wayside until babies are like ready to go home. Whereas for me, that's one of the roles that I like to play is educating families on the importance of this early vestibular stimulation. And while we might not be able to turn them upside down, we can introduce rocking safely as early as 32 weeks, according to the evidence. We can have parents hold them and move in different planes to give them vestibular input. We can give them a lot of different types of movement experiences in safe ways. And it's important to do so as early as safe as possible for that vestibular development. And then, I would love to see studies about kind of like long-term correlation with like vestibular seeking or vestibular avoiding kind of behaviors in preterm infants who don't have that as much of that early stimulation. That's one of my many research studies I would do if I had the time and the resources. So yeah. And we need to like collaborate, with the inpatient and the outpatient, because then we can get like that whole spectrum of like, okay, what are we doing in here that impacts what you're doing out there? And what are you seeing out there that we need to like help in here? Like, it just would be so cool to have more collaboration.
I agree. It totally would. Well, and it does bring to mind, in the past working with a child who did have a G-tube and who disliked tummy time, but also this child disliked vestibular-based activities. They were very gravitationally insecure, very low muscle tone, didn't like to do climbing activities or slides, was very hesitant. And it just, makes me think that there wasn't that education when this child was in the NICU. The education wasn't provided to the parents on the importance of these things.
Yep, absolutely. And I think that's changing as we are doing more research about neonatal care, and neonatal therapy is becoming just more prevalent in, medical literature and areas of study. I think we're learning more about the importance of those things. And there's already programs that are rolling out about providing graded, safe vestibular input, sensory input, auditory input, movement experience based on gestational age. So we are starting to think about it more in like a developmentally holistic perspective. What I often describe to people about the NICU is that like babies are in this safe, protected environment typically when they're in utero, and then they're born and they're thrown into this chaotic medical environment that is nothing like what they were experiencing before. And so we really try hard to provide that protection. And sometimes we go a little overboard by just protect, like no input, no light, no auditory, no touch, like very little touch, as little as possible. And while that's, some of that protection is really good for babies, we obviously want to reduce their stress. And so we want to be mindful of how they're reacting, but also that safe stimulation is also so important. So it's this balance of protection and stimulation. And you really, like, we can have all the guidelines we want, but as we know, working with kids, is that every kid is different. Every baby is different. And so the most important thing, I think, is teaching parents and providers how to read babies' cues, how to read premature stress cues and premature infants' approach cues. How do we know that they're happy or they're upset when they don't have a full cry and their reactions are immature and they're different than a full-term baby would be? And so, part of my role as a neonatal therapist is teaching parents about that, about how to read their baby's cues and how to respond appropriately.
That's a good one. Yeah.
I think too, as a parent now, if I had a baby in the NICU, my goal would be like, don't stress them out. Be careful. Like exactly like you said, I'm going to take them home and I'm going to be so nervous that they're going to get hurt or something's going to happen. That sensory input is like not on the forepart of my brain. How do I say that? It's in the back of my brain. Like I'm not worried about giving them a wide variety of sensory input. I'm worried about keeping them alive, right? Which obviously is our priority. But I think too, if that education is there and we can say, here are some things to continue to stimulate them and keep them regulated. And then talking about down the road what that looks like too, and also teaching them what to look for. Like if you're noticing these signs as they're 1 or 2, like here's what we can do, or like come back and let's work on that. Ideally they'd be in early intervention and that can be monitored. But I think too, having that verbiage of this is sensory processing challenges, this is retained primitive reflexes, this is a vestibular like explaining that to families who that's not what they're thinking about. They're just like, I want my baby to be healthy.
Yeah, and that's so true and that's so valid. And I have not had a baby in the NICU. I'm not a parent, and so I really can't relate to that experience personally, but I see it every day at the bedside, and it's so true. Ultimately, the most important thing is to keep your baby safe, and that's what we're here for. And so I think as we're learning more about this, we can say with more confidence what is and isn't safe. And what the research is showing us is that especially parental touch and parental involvement is nothing but positive. We know that when parents are able to be at bedside, when they're able to put their hands on their baby, even very early on, when we facilitate skin to skin time, even with really small, sick babies, not only is it safe, but we see babies' stress levels decrease, their cortisol in their blood decrease, their sleep improve, their length of stay in the hospital decrease, their time towards oral feeding is shorter. Like literally every outcome that we measure when parents are touching their babies is safe and it's positive. And so I think partnering with the medical team and the parents is so important as neonatal therapists with this knowledge and this information that we have. And we can help set this up in a safe and successful way so that parents can do skin to skin early on and that babies do get that benefit and parents get that benefit too. And I really try as babies progress to kind of be constantly talking about these, maybe they're not milestones, but they're mini stones, like these babies are making really important steps forward towards progress where as the babies are progressing, we also, as their supportive care team, have to progress. And we have to recognize that this time of like ultra protection, we need to expand it and we need to be thinking about development. Otherwise, we're going to be doing them a disservice down the line. And to your point, I think making sure that babies, especially who are at high risk of having neurodevelopmental challenges, need to be connected with somebody in the community or with the hospital system, either through early intervention or home health or a private outpatient clinic. At my institution, we're lucky to have a NICU follow-up clinic. So babies who meet certain criteria, who are at higher risk of having neurodevelopmental challenges, they always get a referral to come back and see us, where we do a multidisciplinary visit and kind of look at all different aspects of their development and how we can best help. So having a care team that is going to follow them after they go home to support them and continue to give these babies, you know, the best start to their life as possible, even in the midst of medical challenges, is so important.
Yes, so much so, yes.
I love that.
You mentioned oral and feeding. What is your role in a baby learning how to feed in the NICU?
Yeah, great question. So it depends on your NICU, kind of who does most of the feeding. So when I worked at Seattle Children's Hospital, we had a multidisciplinary team, and there were people who were PTs, OTs, or speech who all had feeding experience, who would all feed babies. Here at St. Luke's, we also have like a specialized feeding team, which I focus more on the developmental side. And so my role really is to kind of like prep babies from a sensory perspective so that by the time they're getting to the time of eating, that they're used to having input around their mouth. We do a lot of facial massage. We do a lot of like kind of stimulating oral reflexes. I introduce a binky as soon as possible to give like developmental stimulation, even if babies are still intubated or they're on CPAP. Like, we adapt the binkies and we have different sizes, and we try to work on that early oral motor stimulation and input so that by the time they're working with the feeding therapist, it's not brand new to have something in their mouth. It's not brand new that they've had to like rhythmically suck. So I don't do the feeding work, but I try to help my feeding colleagues out by doing some of that early sensory and oral motor stimulation prep work.
Yeah, that prep is so important.
Yeah, I do feel like that's something that, again, is missed. Like, even for older babies or, you know, babies who are born at 40 weeks and, you know, we're not getting in their mouths, and all of a sudden they're starting solids and they're like, what is this? And it's like, we can prepare that, and there's so many things that we can do to get them ready to start that and just desensitize in a way.
Absolutely. And we know that there's so much changing and growth that happens in the brain in the first years of life, that neuroplasticity is happening at a rapid speed. And so if we can, from the very beginning, kind of help prime their brains for these different types of stimulation, we're going to set them up for those skills rather than, you know, having to like later on down the line go back and kind of like change how their brain has developed. So I heard a mentor describe neuroplasticity as like, you know, we can be there from the building of the foundation of a solid house, or we can come in after the house is built and kind of like have to do all these remodels because the foundation was altered, right? And so of course, you know, the idea of like, you can't teach an old dog new tricks. You definitely can. And there's always room for improvement. And even adults, we are able to grow and learn and change. But if we can take advantage of that like early foundation of their brain mapping, then we can really set them up for success in the future.
That's so true.
I love that. Yes. Okay, I think it would be helpful to share just a few tips on helping kiddos reach those gross motor milestones who maybe have delays or who were maybe preterm and they are just struggling to reach some of those milestones. Can you share some of your go-to tips?
Yes, I think some of them are more just theoretical for parents to have education which can empower them to help support their babies. So one thing to keep in mind with preterm babies is that when looking at developmental milestones, we always correct for prematurity. So if a baby was born 2 months early, we are looking at their motor skills of not a baby, not what their actual age is, but corrected 2 months earlier. So if they're 4 months old, and I'm going to be looking at their motor skills, I'm expecting them to have skills of that of a 2-month-old. And it's really important to keep that in mind, because if you're thinking just like after you go home from the NICU that your baby is however, 4 months old and you're kind of expecting those milestones, you're going to think that your baby is having more significant delays than they might be having, because we give them credit for that time that they were kind of like in the NICU and still developing from a fetal perspective. So always correct for prematurity. We do that until babies turn 2 when we're looking at standardized testing. After that time, usually most of the prematurity related delays have kind of worked themselves out, and then we can kind of just test them at their chronological age. Every baby is different, like we said. So I think having some general understandings of like what the milestone expectations are is really helpful. And one thing I see a lot is what I call milestone anxiety with parents, is that their pediatrician gives them this checklist of by 4 months they should do this, and 6 months they should roll, and 9 months they should crawl, and 12 months they should walk. And babies are really variable, and their environments impact a lot about how their development changes. And so having a general guideline is helpful, but always remembering that every baby is a little bit different, and kind of meeting that baby where they're at instead of where they are expected to be. So if we have a baby who's having challenges with rolling and they're 9 months old and their parents want them to be working on crawling, we're not going to be able to work on crawling until we really are able to master that rolling. And we have to kind of work with the baby where they're at to like progressively work up to those different milestones. And milestones are changing also. They were recently updated by the CDC to reflect the changes in kind of the overall population's development. And some of the reasons for those shifts are because of the back to sleep program from the 90s, where now we put all babies on their backs, which is good because it's reduced the rates of SIDS or sudden infant death syndrome or sudden infant unexplained death. But what it has done is it's shown a shift in milestones because babies aren't getting as much tummy time. And we know that tummy time really helps to promote motor development. So having an understanding of what is realistic as far as timelines for developmental milestones is really important. And then always listen to your gut. I always tell parents, don't wait and see. When in doubt, check it out. I love little rhymes. So no more wait and see. When in doubt, check it out. And, talk to your pediatrician about getting a PT or an OT referral as soon as you have worries, because there's no harm that can come from it, right? If nothing else, we evaluate the baby and we say that they're on track and give them some recommendations, and the baby had a nice little play session and you go on with your day. On the other side of things, if there are delays, if we can catch them early and we can intervene early, then we can take advantage of those periods of neuroplasticity and really optimize their development.
Yeah. I didn't work with a kid. I had a friend who had a kiddo who was just a happy sitter, just so content just sitting. And she was like, "That's what I do." And she's like, "Shouldn't he be crawling?" I'm like, "Yes. And she went and got PT, and they got him crawling, and it was just in and out and get some strategies, and he caught up and, crawled for a while and started walking and did all the things." And I'm like, a lot of it is that environment too, being the youngest sibling and just watching and checking it out and just feeling comfortable in that. So I think that's so important too. There's a stigma around needing therapy and parents just a lot of times think, it doesn't matter, or they don't need to crawl, or rolling doesn't really matter if they do it both ways, but there's just so much information out there, and you touched on it, of how important it is that they do hit those milestones, and they're like the building blocks, we need that strong foundation.
Yes.
Yeah. And another point, just kind of touching on your comment about the environment, another point about the environment that I think is really important for families to know about is that there is a significant kind of phenomenon in our American society in particular called container baby syndrome, where babies are showing developmental delays, not because of a neuromotor impairment or, kind of a challenge with their brain's development, but because of their environment not being varied enough and being restricted through what we call containers. So bumbo seats or swings or jumperoos or standers, those are all considered, even the car seat, those are all considered containers that, while they do kind of keep the baby contained and safe while parents can do other things, they really restrict movement. They do not allow babies to explore their bodies, to stretch their muscles out, to wiggle around and kind of experience movement and exploration like floor time does. So the general recommendations for container time is limiting it to 30 minutes a day and then doubling up the amount of floor time. So if baby does spend 30 minutes in a container, in a stander or in a bumbo, then they should spend an hour on the floor playing and stretching and wiggling. I never, as a pediatric PT, I never recommend jumpers. If we think about when the skill of jumping happens, typically with kids, it's between 2.5, and 3. And we're going to put these infants with immature joints and muscles that are not ready, in this device that's going to encourage repetitive, high impact, pressure on their joints that aren't ready. It also can make it harder for babies to tolerate just being standing still because they're used to this like kind of excessive vestibular input. So jumperoos are not my favorite, but what I tell parents is that obviously you have to put your baby in containers. There are times you need to make dinner, you need to do chores, you need your baby to be safe and in a stable position. So think of containers as a tool for you as a parent. Don't think of them as like an assistant for your baby's development, because really the best thing for your baby's development is to be on the floor, moving around, playing with you, and exploring their body.
Yeah. You're speaking our language.
Yes.
This is something we talk about a lot
Yes.
too, especially the containers. So yes.
Yeah, and my thought is these containers, if a baby can't sit on their own, why are we putting them in a container that's facilitating them to sit? If they can't stand, why are we putting them in an extra saucer where they can stand supported? The milestones are there for a reason, so that way they can get to those points. But if we put them in there prematurely, it doesn't help them, So if
they might not be ready
on their own, then let's not put them in a container that facilitates them to be in that
And
situation.
I will say, like, we're talking about babies who are developing in a relatively typical trajectory.
Correct.
For babies with medical complexities and disabilities, that looks a little bit different. And so having like medical standards and medical equipment is really important and really helpful for babies who do have disabilities. So that's kind of a different conversation. And I really am passionate about making sure that babies with cerebral palsy, for example, do get opportunities to work on standing and upright skills at a kind of age appropriate time period, even though they can't do it on their own, because it gives them really good visual stimulation and, lets them explore their environment more and helps with bone density and, skeletal growth and postural growth. So I am a big fan of using like medical equipment for facilitating different postures for children with disabilities, but that's kind of a different conversation than like excessive container use in typically developing babies.
Yeah, definitely.
I'm glad you brought that up too, because that's not our area of expertise, and I think that is true that if for a child with CP who doesn't have the capability of standing, like we do need to give them that input. And so maybe we should have you on to talk about that on another day.
I would love to.
Is there anything else that you can share with us, maybe specifically for other therapists who are working in the NICU? Any advice that you can share for someone who's there?
I think one of the hardest things about NICU therapy is getting into the NICU. I think it's kind of the subspecialty that is sort of like, if you don't have experience, people won't let you in, but how do you get in if you don't have experience? And so I think if therapists are interested in getting into the NICU, really try to build up your experience with infants in whatever setting you can, and do some learning, some online learning as much as you can. The National Association of Neonatal Therapists, or NANT, is a wonderful resource for like virtual webinars that talk about all things neonatal therapy. And then seek out mentorship. I'm always happy to be a resource for people because I remember what it was like when I was trying to get into the NICU. And so I think just getting access to education and mentorship is so important for being a skilled and competent and compassionate provider in the NICU, but it's such a special place to be.
Yeah, I know. I don't even think I've ever been in a NICU, and it just sounds intimidating.
It can definitely feel intimidating, but with the right support, it's one of the most special settings to work in. I just really value being able to be a sense of support and encouragement and empowerment for families in the middle of just one of the most intense medical experiences.
Yeah.
Well, thank you again for coming on. We appreciate it. We'll have to get together since you're in Boise now. But it was
yes, for sure. Thank you so much for having me. It was a pleasure. And thank you for all the important advocacy and awareness work you guys are doing around sensory development and childhood development. It's so important.
Thanks, Angela.
Thank you so much for listening to All Things Sensory by Harkla.
If you want more information on anything mentioned in the show, head over to harkla.co/podcast to get the show notes.
If you have any follow-up questions, the best place to ask those is in the comments on the show notes or message us on our Instagram account, which is at Harkla_family or at All Things Sensory Podcast. If you just search Harkla, you'll find us there.
Like we mentioned before, our podcast listeners get 10% off their first order at Harkla. Whether it's for one of our digital courses or one of our sensory swings, the discount code SENSORY will get you 10% off. That's SENSORY.
Head to harkla.co/sensory to use that discount code right now.
We are so excited to work together to help create confident kids all over the world. While we make every effort to share correct information, we're still learning.
We will double check all of our facts, but realize that medicine is a constantly changing science and art.
One doctor or therapist may have a different way of doing things from another.
We are simply presenting our views and opinions on how to address common sensory challenges, health-related difficulties, and what we have found to be beneficial that will be as evidence-based as possible.
By listening to this podcast, you agree not to use this podcast as medical advice to treat any medical condition in either yourself or your child.
Consult your child's pediatrician or therapist for any medical issues that he or she may be having.
This entire disclaimer also applies to any guests or contributors to the podcast.
Thanks so much for listening.